Good morning, everybody, and a warm welcome to this webinar on cardiac care during the Corona era. Coronavirus has spread relentlessly across the world. Though it affects the respiratory system, primarily the lungs, it could also affect the heart, especially a diseased heart. So heart patients need to take extra precautions to reduce their risk of contracting this infection. To elaborate this further, we have with us today globally renowned heart specialists Dr. Ashwin Mehta and Dr. Suresh Joshi. Dr. Ashwin Mehta is the Director of Cardiology at Jaslok Hospital. He started cardiac catheterization and angiography in newborn babies in 1973. He was the first one to start bundle electrography in India in 1973. He has performed cum supervised more than 50,000 angiographies and more than 10,000 angioplasties. He was the pioneer in conducting primary angioplasty in acute myocardial infarction with the first systemic trial in India. His main expertise is coronary intervention, rotablations, balloon valvotomy, and transcatheter aortic valve replacement. He has been bestowed with several prestigious awards both at the national and international levels, including the CTO Man of the Year Award, the first of its type for the Indian chapter of Second Indo-European course on revascularization in 2008, Lifetime Achievement Award at the first IGCTO meeting in 2013, Golden Contribution Award at AICT in 2012. So it is truly an honor and privilege to have you with us today. I now request you to please deliver your address on management of acute coronary syndrome during the COVID era.
Thank you for your introduction. And it's a pleasure to be with Dr. Suresh Joshi. My association with him for nth number of years. Let me share with you, my friends, when I started angioplasty, we were the first ones to start in our part of the country. And in the first 1 year, there were 16 patients who required an emergency bypass surgery because of acute catastrophe. And one patient was in cardiac arrest, shifted with the cardiac massage to the theater. And these 16 patients, every patient, thanks to Dr. Suresh Joshi and his team, every patient went home. In those days, there were no stents. There was just a balloon angioplasty. Balloons were primitive. And Suresh Joshi is a fantastic support and help that we could fire the guns on his shoulder, the strong shoulders. Thank you, Suresh, to be with us today, and I appreciate. So now, question is that all these years, my friends, we were treating, somebody gave a call in the middle of the night that I'm having a severe chest pain, what should I do? And then, well, you ask him, I'm 50, 55, I've been a smoker and I have diabetes. And this is the first time in my life I got chest pain and I feel very much better if I sit upright. It will not take you much time to make sure that the probabilities that this is an acute coronary syndrome is very, very high. You are not going to, like in olden days, go and rush to the patient's house with an ECG machine and then make sure that you are dealing with an acute coronary syndrome confirmed with an ECG. No. You are going to tell him to rush to the nearest hospital. Well, now the question is a little bit different. What has made change once the COVID-19 has come in? What has happened now? What different? Well, we now have started realizing that COVID-19 by per se on its own can present with the cardiac symptoms. On top of it, COVID-19 will make the cardiac scenario much more sinister, much more serious. Impact of COVID-19 on pre-existing heart disease, which patient might not knowing, you might not be knowing, is bad. On top of it, irrespective of a presence of heart disease, COVID-19 is capable of producing cardiac abnormalities, cardiac damage on its own, and present as an acute myocardial infarction. When an acute myocardial infarction is associated with no atherosclerotic changes at all, you call it as a secondary myocardial infarction. Secondary myocardial infarction, for example, stress myocardial infarction, what is described is called Takotsubo syndrome. In that situation, what happens is the coronary arteries are normal. Presumably, etiologically, there could be intense spasm of the proximal artery, commonly in females, post-pregnancy, postpartum period of time, but at any point of time, anyone who's under a lot of stress can develop an anterior wall myocardial infarction called broken heart syndrome. That also, I think, would be increased in the stress of COVID-19 without COVID also. And that occurs comparatively young people with normal coronaries. So COVID-19 has modified our insight, our looking at the problem, our attitude towards it is changed and changed unfavorably, very, very unfavorably. Now, when the patient comes to your IC, your admitting room area, now what do we do? Well, first of all, let's say I do believe that there are a lot of family physicians who are joining my webinar. And then I think I have to keep everybody in mind that we all health workers, we have to work in a team like a chain. And then the first call is going to be to family physician who wastes no time in recognizing that this could be acute coronary syndrome. There could be an instance where the family is not very sure and the description is vague and may require you to visit the patient. And at that point of time, you may have to take an ECG and with protection. Enough has been said about how to protect yourself. PPE1, PPE2, PPE3, and I don't want to bore you with those repetitions. I just want to tell you specifically how will you deal with this particular situation on the background of COVID-19, which is pandemic. And in Bombay, it is just not knowing any margins, spreading like a wildfire, and amazingly disturbing. I think it's just simply terrible. All right. So when he goes to the hospital, the doctors, first of all, wants to protect. Unfortunately, till yesterday, the COVID test would take approximately 24 hours. And now I think in hospitals like major hospitals like Jaslok Hospital, they are able to give the report in 6 hours. But we found one more thing. Our radiologists taught us that the COVID-19 radiological science with HRCT can be helpful even in those patients in whom COVID-19 test is the what should I say, RT-PCR test, the throat swab test may be misleadingly negative, and in that situation the HRCT will be helpful because it will occur in 15 minutes, and I think you should use it profitably. The attitude in general is, unless proved otherwise, everybody is COVID-19 guilty. Everybody, irrespective of age, everybody is COVID-19. If you know for sure that they're COVID-19 negative for an elective problem or a semi-emergency problem where the patient is come with the COVID test, well and good. Then I think it is fine. But otherwise, unless proved otherwise, etc. Now let us see. It has been declared as a pandemic on March 11th, 2020, and primarily it's a respiratory virus, but we know that it is now producing thromboembolism in the various blood vessels, including producing strokes, acute myocardial infarction, pulmonary embolism, and even the peripheral vascular complications. The risk factors we all know very well, but a low immunity and post-heart transplant, the people who are receiving immunosuppressants are particularly at a much higher risk in this is COVID. Now, severe involvement in the form of myocarditis can complicate STEMI diagnosis. In what way? Well, ST changes are well known to happen in COVID-19, which has a cardiac involvement. Okay, TROP-T, TROP-I, yes, they can be elevated in both. ACE receptors which are elevated in hypertensive patients and IHT patients may also confuse the issue, and then patients demonstrated by Kwong and colleagues that who have an acute respiratory infection are at an elevated risk for subsequently developing acute myocardial infarction, significantly high rate. So the complications of COVID, complications of coronavirus is following in cardiac, especially I'm talking of cardiac. Acute myocarditis, acute coronary syndrome, arrhythmias and cardiac arrest, cardiomyopathy, acute heart failure, cardiogenic shock, and venous thromboembolic disease. These are primarily the disorders. If there is a pre-existing coronary disease, it will be precipitated and may turn out to be a little more serious, but otherwise on its own, these are the manifestations of COVID-19. Okay. And I'm not going to talk about this, that we might have to change our treatment modalities. We have to modify them, but we'll talk about it a little later. Okay, those patients who are stable at the time of the onset and within first 12 hours, they should be given thrombolysis immediately and PCI after the infection clears. This thing, in my opinion, mind you, these are not guidelines, these are guidances. When would the guidelines come? The guidelines come only after a good number of RCTs, randomized controlled trials. Where are the randomized controlled trials? There's no time and there's not ethical to do a controlled trial in a situation which is life-threatening. So therefore, these are the guidances. I personally feel that a patient who comes with an ST elevation myocardial infarction, whose COVID status is not known to me, I would consider him as COVID positive. But now, having taken as much precaution to consider and make the whole environment COVID negative or COVID impermeable, I can't call it COVID negative, but COVID impermeable to either me or to my patient, then I think one could give the best and optimal optimal line of treatment rather than a compromise. I foreknow that thrombolysis is not a superior form of treatment to primary intervention, primary coronary intervention. In PAMI, what we call it is, no, it's not superior at any point of time. Forget about superior. But at no point of time, PAMI can be inferior, even in the first 2 hours. It has been documented that if the thrombolysis is administered in first 1 to 2 hours, it is capable of producing equivalent results. I agree. I don't deny the trial. I don't deny the data. I agree. But what about the risk stratification? When I do an angiography, I know that 5% of the patient with inferior wall myocardial infarction can have a left main disease. Do I need to be ignorant about it? Almost 45 to 50% of the patient who come with acute myocardial infarction has a multi-vessel disease. Do I afford to ignore it? All right, no problem. 15% of the patient who get admitted today, by the natural history, will develop another coronary event in less than 3 months' time. Why do I ignore it? I need to have an angiography. An angiography is a roadmap to PAMI. I don't do angiography to do thrombolysis, no. Agreed that when the situation was very acute and when we didn't have the test, thrombolysis was immediately. But those stable patients who come late, then I think they should be first try to do the infection control, find out whether they have COVID. If they have COVID, yes, then I think infection control, treat them conservatively. They are outside the window period, probably whatever damage was to be done has already happened, and perhaps some of them were secondary myocardial infarction. Incidentally, I forgot to tell you, about 5% of the patients who come with acute myocardial infarction, irrespective of COVID status or pre-COVID era also, they were having no coronary disease at all. Nothing. 5%. So they will get thrombolytic therapy unnecessarily. COVID therapy is always a after proving. We don't give anybody COVID treatment. After all, initially, COVID treatment is conservative, and no treatment in a mildly symptomatic patients or asymptomatic patients is necessary also. Let us proceed further. What about unstable patients with severe pneumonia? Transfer immediately to isolation ward for conservative. The protocol which I would advocate and which is in place right now in the Jaslok Hospital and many other hospitals where I go is to not to hesitate in offering high resolution CT of the chest, for the simple reason that it is not only an additional value, but sometimes it precedes. It precedes before the COVID test for you come. And you know, negative, positive, the sensitivity and specificity of COVID-19 test, RT-PCR test, we all know very well it has limitations, and therefore combined together, both together, the specificity and sensitivity is considerably increased for actually optimize the treatment appropriately. And the unstable patients with a mild to moderate pneumonia, assess whether the onset time of STEMI is longer than 12 hours, and then infection control, and then to the PCI. All right. What about non-STEMI, non-ST elevation myocardial infarction? Well, this has been always the one option, that wait and watch therapy or dead and neck therapy. Wait and watch means, I believe that in vast majority of the cases, when the patient comes with the non-ST elevation myocardial infarction, they may give you an opportunity to stabilize them. Why stabilize? If you're going to do something, you might as well do now. What will happen tonight while waiting? Well, no, there is a problem. A stable patient's outcome is always better. A man pre-treated with the anti-platelet agents, beta blockers, and stable, then gives you a very comfortable moment at the cath lab, and you may be able to treat him and give him a little more margin of safety. On the other hand, the patient who has a repeated bouts of pain or unstable hemodynamics, irrespective of COVID, he should go to the cath lab, because we know very well that the non-STEMI, STEMIs is gradually reducing because they are treated at non-STEMI stage, and non-STEMI treatment with the PCI is unequivocally agreed upon, is clearly far, far superior outcome as compared to medical therapy. So therefore, this is the situation for unstable patients. So now, confirmed COVID-19 patients, and what am I going to do to the confirmed patient? Well, if he is an NSTEMI or STEMI patients, take him to the cath lab if he has got an ongoing ischemic symptoms or hemodynamic compromise. Do an angiography, offer an angioplasty if possible, or meanwhile, he should be under the observational ward, which I think in undeterminate, like not COVID negative, not COVID positive, but an observation area, which I think every hospital has already triaged it, and therefore no problem. And then control his infection as best as you can simultaneously with the help of your respiratory physicians or intensivist, whosoever is supporting you in COVID management simultaneously. And those people who are otherwise stable, maybe in this current era, you don't want to unnecessarily expose yourself to the COVID environment, make a medical management and do a CAG as soon as the patient is less infectious or reasonably stable. What about refractory symptoms? Surely, I mean, if he is posing threat, you have to go ahead and perform coronary angiography. What about elderly patients with corona? Those who are above the age of 65. They are advised for social distancing and self-isolation, should probably not undergo elective procedures until the better control of the situations. But those who have an accelerated symptoms, as they felt to be unstable, then I think elective cath lab procedure should be offered to them. Possible COVID-19. Those who are possible. If there is a STEMI, primary PCI is, in my opinion, is the treatment of choice. Take the maximum precaution to protect and make the environment COVID non-permeable to him and to you, to both, because it's possible. He's not a pure proven COVID, and it will be terrible a COVID negative patient goes out of the hospital COVID positive after his treatment, that I think is I think shameful, and therefore one should be very, very careful. While he's undergoing treatment, make sure that he is COVID protected fully, completely, as best as you can. Well, non-estivation myocardial infarction in a COVID possible patient, await coronary angiography until negative COVID-19 test. Exceptions I already told you, not a problem. Don't worry about this very complicated slide, that here electively the thrombolysis was a preferred modality of treatment. There are patients in whom thrombolysis may be negative, contraindicated, and there are sizable number of them. Why contraindicated? For example, I gave you that 5% of the patients have a normal coronary artery, not in coronary angio, and therefore you are treating empirically. And they have normal, and they are exposed to the risk of bleeding, and the benefits of the thrombolysis is none when the coronaries are normal. Forget that part. What about cases in whom there are thrombolysis negated because these patients have a stroke only a month back? That's terrible. I think that's an important contraindication. Or he had some major surgery. So what about that? And if that is so, I think there's no other choice but to offer them an invasive form of treatment, that is angiography. And angiography findings will dictate you what further to do. All right. So, and then this is about non-STEMI. And now response levels. If you're a STEMI, then minor restrictions in regular services, level 1, level 2, level 3. Let me summarize the whole slide. If the patient has a STEMI and there is a moderate or high risk probability of COVID-19, then you should have a protection level of PPE2 or PPE3 when you take him for the cath lab. Anyway, level 3 is those where there is a complete inability to provide the invasive treatment, or for some problems with the staff, I think that the medical management. And I think there is also a possibility that in city like Bombay, where I think number of patients have a round-the-clock facility to offer primary angioplasty, so therefore there is no problem. But in a smaller town, it may be a problem. Now, take-home messages. Cath labs need to carefully weigh the balance between the staff exposure and the patient benefit. Case decisions is individualized, taking into account the risk of COVID-19 exposure vis-a-vis the risk of delay in diagnosis and therapy. When PCI is performed, the cath lab team must wear personal protective equipment fully and also keep minimum amount of time, not over-enthusiastic treatment. Make the procedure safe and short. Don't try to be over-enthusiastic that you will open a chronic total occlusion on the table at that point of time, which I think can surely wait very much and surely is going to take long time. Exposure is long and the risks are high. So with this, I would leave some time for questions and answers. And Shril Maniar, I would like to stop at this point. Hello, Suresh.
Yeah, hi. Good morning, sir. How are you?
Could you hear me clearly?
Yeah, very nice presentation. I liked it.
Yeah, very nice presentation.
Did you hear the opinions about you that I expressed?
Unfortunately, no. You can do it again some other time.
Well, right now I will tell you that I told the people that I fired the guns on your shoulders when I did my first angioplasties in the first 1 year. 16 patients were sent to you with a crash. And one patient I can never forget had a cardiac arrest in the cath lab. We brought him to the theater with cardiac massage. We opened the chest with one hand, continued to give cardiac massage, and that patient went home. I will never forget your support to our angioplasty program, Suresh.
So kind of you, sir, but I think those were the learning days. And if I can recollect correctly, the hardware that was available was really not up to mark. And over the years, now we have come to a stage where you almost require no standby from the surgeon and you're able to do angioplasty without the active cardiac support, except for an exceptional cases, of course.
but still obligations are obligations.
So kind of you of your kind words, sir. Thank you.
Okay.
Thank you, Ashwin Mehta, sir, for your very informative presentation. I now request, it's a pleasure to have our next panelist is Dr. Suresh Joshi, who is a highly qualified and experienced cardiothoracic vascular surgeon with over 30 years of experience, primarily in aortic aneurysm, complex heart valve repair and replacement procedures. He pioneered minimally invasive heart surgery and beating heart coronary bypass surgery in India and has performed more than 15,000 procedures to date. He established open heart surgery in Mumbai and Western India. He has received numerous accolades and awards, including the Medical Excellence in Cardiac Surgery in India from Harvard International University, USA in 2009. Dr. P.K. Sen Oration in Minimally Invasive Cardiac Surgery from Indian Medical Association of Cardiovascular and Thoracic Surgeons. Dr. Joshi, it's truly an honor and privilege to have you with us today. I now request you to please deliver your address on cardiac surgeries in COVID era.
Yeah, thank you. I started open heart surgery in newborns in Mumbai, or for that matter, Western India. But open heart surgery was started way behind by Dr. Sen and Dr. Dastoor. Yeah, I'll start with my presentation on cardiac surgery in the COVID era period. Now, Dr. Ashwin Mehta has already touched upon the situation of COVID, and it's kind of made my job sort of easier at the cost of being some part may be repetitive because I might cover something very concerning COVID. So as we know, now already the number of COVID cases are increasing by leaps and bounds. At the same time, fortunately, the initial panic and the fear seems to be weaning off very rapidly. The lockdown period, which was earlier, has now come to an end, and that has further increased the cases. But during this lockdown period, the authorities got adequate time to establish the capacity building and additional indoor beds as well as ICU facility. So now there are no shortage of beds, as I understand, for COVID patients. Now, during the however, during the lockdown period, there was a huge disruption of routine medical and surgical, particularly the surgical cases in general, because surgery is usually dependent on logistic support system. You know, we require a lot of other supporting elements for conducting even general surgery. So, as against pure medical management. And also at that time, during the lockdown period, the lot of ICU staff and most of the hospital personnel were directed more towards COVID management. And now that the things are in place, the ICU and the emergency services, and now from now onward, even the routine surgery has been well established. Now, emergency cardiac cases were largely crippled because of inadequate logistic system, as I mentioned, because there were two reasons. One was medical, which was case selection during the lockdown period, because there was not enough knowledge about how to handle these cases. Dr. Mehta has already mentioned that these protocols and guidelines cannot be established overnight and quickly within days or weeks. So we have to go by our own experience and the local government regulation as well as the local situation of availability of resources. So based on that, we have been now trying to follow the new sort of guidelines. Just to touch upon the problems that we had, the public transport was not there, so we could not even do emergency cases sometimes. Even the blood bank, which is such an integral part of open heart surgery, we couldn't get blood because there were no blood donation camps. And not too many relatives were allowed to come and donate blood. And now India, as we know, is fairly or in fact very well advanced in tertiary care, particularly in cardiac. And it's no exaggeration to say that we can offer any cardiac care like any other country in the world. But unfortunately, it is more concentrated in the metropolitan cities and it's not reached to all over the country. As a result, large number of patients have to travel to cities like Mumbai, Delhi, and so on. And due to lockdown, they could not travel, and the whole care or tertiary care was grossly affected. And even those who would manage to come by road, they couldn't get accommodation because all the hotels and dharamshalas, they were closed down. Now, over the period of last few months, a lot of European and American institutions have sat down and tried to, with their limited experience, tried to make a recommendatory guidelines sort of, and to what kind of cases routinely or in emergency basis we should do, or how we can resume the normal routine activity. So based on that, the first thing that they have recommended is that the cardiovascular services is the first thing that should be resumed compared to any other specialty. That was the strongest recommendation, because possibility of high morbidity, not only morbidity but mortality is associated with cardiac cases, and so also the incidence of COVID is much higher with patients with cardiac cases. Now there is one paper which I am going to briefly discuss before I actually go to the management, how we are managing the routine cardiac surgery. Now this is an extensive study of more than 1,000 cases published just last month, 2 weeks back in Lancet, which gives us a kind of a guideline or the idea of what are the outcome of operating on a patient who is COVID positive. I'm talking about patients who are COVID positive, not those who are COVID negative. So there were like 24 countries and 235 hospital data was studied. And earlier, as I said, not only us, but everywhere in the world, nobody knew which cases to operate, which cases not to operate, whether to operate on COVID or not. So they operated all the cases, and they realized that the overall mortality in these more than 1,000 cases was close to 24%, and particularly higher in those who were emergency cases. But they were not less even in elective cases. These are possibly the earlier experiences where they did not realize whether to operate on routine cases or not. Because not all the countries had that severe affection of COVID. So in initial phases, maybe they have operated on some of the COVID patients, and they realized that it is not proper to operate on the COVID positive patients. Another thing that we noticed that those patients who had pulmonary complications after cardiac surgery had almost close to 40% mortality, as against those who did not have any pulmonary complications, so which was just about 8%, which is also high by routine standard, but they also included some of the emergency cases. So by and large, those who have good lungs or do not develop any pulmonary complications have reasonable outcome, even if they are COVID positive. The other thing that they have noticed is that those who are above the age of 70 or those who are male, they have a higher mortality compared to those who are below the age of 70 and in female patients. So bottom line is that those who are above 70, these are the danger zones, or those who have pulmonary issues, lung issues like hypertension, COPD, or they are a smoker, they are probably the worst of patients if they have to be operated if they are COVID positive. So then what's the bottom line? Should we operate on a patient who is COVID positive? The obvious answer is no. But then there are exceptions. The answer is no because the mortality reaches to almost 20% plus. And today in cardiac surgery, in any reasonable center, we are talking about mortality risk of hardly 1%, or maybe in a very high risk case. When you say high risk, it's just about 2 or 3%. So that is the kind of results we are expecting in most established cardiac center. So compared to that, the mortality of 20% plus is too high. But there are exceptions to this kind of a guideline, that even if you are COVID positive, then in an emergency situation, one may consider operating on these patients when you perceive that the risk of operation is possibly less than not operating. Now, what are these conditions? I can't list all of them, but majority of them include like aortic dissection, dissecting aneurysm, or patient with unstable angina who is not amenable to angioplasty, or if there is a complication, rare, but although it can happen, is a failed angioplasty. What do you do in that situation? Or a complication of thrombolysis like post-infarction ventricular septal defect, or acute, sometimes because of post-infarction they develop acute valvular regurgitation. So these are the kind of patients who are really desperate, and they will surely will not make it without going for surgery. So the risk is probably much higher than 25% without an operation. So these are the kind of patients we will have to take up for surgery with added risk. But I again would suggest that these kind of patients should be operated in a center like Jaslok Hospital, where we have a very good backup of intensive care, and especially the ECMO standby, because the primary involvement of COVID is into the lung. In fact, one of the definitive long-term support treatment for patients with extensive COVID is ECMO, veno-venous ECMO support. That is one of the well-known and defined treatments. So if you have ECMO support, you have far higher chance of recovery after cardiac surgery in spite of having COVID positive states. So then now, after the lifting of lockdown, we have completely resumed the routine cardiac surgery at Jaslok Hospital. But only thing is that we are doing it with extraordinary precautions. One is to select a case, and two, prevent this patient who is COVID negative from becoming COVID positive during his hospital stay. Unlike the angioplasty or a cardiac, the cardiac cath cases, the hospital stay is much shorter. Our cardiac surgery patients have to be in the hospital at least for 5 to 6 days, out of which 1 or 2 days are in the ICU. So during that period, you have to take extra precautions that they do not contract COVID infection, because they're during the indoor stay. So there are a couple of tests that we have to do before we plan routine cardiac surgery. One is already been mentioned, RT-PCR test, which is not very, it's only positive in 70% of cases. It's negative in 30% of patients who actually have COVID. So nowadays, we are insisting on doing this test twice, especially for the patients who are coming from high COVID incidence area like red zone area or so. And now, in fact, last few days, this antigen ELISA test is also available. And I'm told that if you do antigen ELISA test and followed by RT-PCR test, and both are negative, then there is a very, very low chance of COVID positive possibility. And also the antibody tests are also available now. And as you know, most of you probably, if IgM is positive, that means there is still active infection, in which case we'll have to wait for a couple of weeks. And if there is IgG already, that means the patient has already suffered past attack of COVID infection, and he can be taken up for surgery. But that's not the only thing. If his antibodies are positive, possibly one may not consider HRCT, but if his antibodies are not positive, then he must undergo an HRCT scan. In fact, I just had a girl last week who had a RT-PCR test done twice. Both the time it was negative. And as a routine, we did her CT scan, and Dr. Desai told me, sir, he's got both the upper lobes are gone white. And she had no symptom at all. Young girl of 22 years old, only admitted for ASD. So I would have put her really in trouble. I put her into that 20% mortality if I had taken her for surgery only based on the RT-PCR test. So the point to drive is that it's very important that they undergo a CT scan before they are actually admitted in the hospital for routine cardiac surgery, even if it is simple like ASD or simple valve replacement. So extra precautions we need to take in two groups of patients, as I mentioned in the previous paper from Lancet, that those who are 70 years and above have a very high incidence of complication and mortality. So one has to be really careful whether you want to really do a routine surgery in them or wait till some more time. But that's again a very tricky question. How much is some more time? Initially, when the so-called pandemic started, and we thought maybe 1 month, 2 months, 3 months. Now it's already 5 or 6 months, and we have no idea how long we will have to wait. So it's really a gray area how long you have to wait for somebody who is 70 years and above for routine cardiac surgery. If you have a very good backup like what we have in Jaslok, I think one would be individualize the case and may take them up for routine surgery with added precautions. Maybe we would like to do, if they have a lung problem, we'll do a complete lung workup, pulmonary function test, maybe involve the nephrologist and pulmonologist before we decide to operate on them, older patients. The additional precautions now, what we take in the operation theater besides the usual asepsis is particularly during intubation, because as I said that there is still a possibility of missing out on certain percent of patients with COVID positive. So it could be dangerous to our hospital personnel, so particularly the anesthetists. So they have to take a precautions of while intubating the patient, and we would like to take post-intubation lavage sample for RT-PCR, which is far more precise for detecting missed out COVID positive cases. Similarly, the expired gases from the anesthesia machine as well as the heart-lung machine are to be filtered out with a filter so that they do not spread into the operation theater. Use of PP is kind of optional for COVID negative patients in those who wish they may use. Particularly the anesthetists would like to use PPE, but may not be because used by other personnel in the operation theater. But generally there should be minimum movement of personnel in the operation theater. And the bottom line is you have to do a very quick and precise surgery and reduce the time of heart-lung machine will run. Because ultimately the major side effect of heart-lung machine is usually on the lung. And if there is a earlier phase of COVID which is not detected, you are going to make it worse by having a longer cardiopulmonary bypass. So that should be another aim to avoid the long surgeries. Now, as far as the post-operative care is concerned, again the aim is basically to do as early extubation as possible. And the suctioning, while suctioning, you have to be careful that you don't use the touch technique, use the indwelling catheter, no touch technique. And the ventilation should be, as far as possible, should be done at low pressure ventilation, because it is very well known that the barotrauma is common in patients who with a COVID infection. So lung have to be all the time protected. And the bottom line is fast track the patient as quickly as possible from the ICU. And even for that matter from the hospital, he should be discharged as quickly as we can. Follow-ups also, now we are more stressing on teleconsultation so that there is not, social distancing is well maintained. Also the reports, we don't like to take the rounds every day, morning, evening, as we used to do earlier, to avoid the unnecessary movement and contact. And we're using social media platform like WhatsApp, even for routine ICU round, because the patient in the ICU these days is so heavily monitored that every parameter is there, and we only most of the time go in the ICU to see the patient mainly for the satisfaction of patient relatives, because they feel like doctor nahi aaye, dekha hi nahi patient ko. But actually when I go and see the patient in the ICU, I already know all the parameters, including 2 temperatures, rectal temperature, peripheral temperature, blood pressure, central venous pressure. So I am not really getting any additional information. So in this particularly COVID time, one should avoid too much of movement into the hospital. So I'm quite sure with this kind of precaution, we will be able to, and we are able to, in fact, we already started doing the same result that we were obtaining of routine cardiac surgery during this COVID period. Only thing is that we are little stressed with the number of beds, but it's not really all that bad. We have still been able to perform a fairly good number of operations, routine cardiac operations with the same kind of results. And I hope and pray that we quickly are able to eliminate this COVID pandemic and come back to normalcy as quickly as possible. Thank you. I'll be happy to take questions, sir, if anybody has any questions.
All right, Suresh. Can you hear me, Suresh?
Yeah, I can hear you.
All right. I think a very informative talk, precise, very nice. I think we have about 125 participants approximately, and then very committed audience. and very inquisitive, thirst for knowledge. So we will be happy to answer. There were some questions. Bharat made one observation, Dr. Bharat Shivdasani, that he had some such patient who was positive, and then he treated the patient for 10 days and then took it up. And I think he had a very, very favorable result. I think once a patient who is COVID positive, and if by any chance you can convert him to COVID negative, then I think you can treat him optimally. Whatever you think would be appropriate as demanded by the clinical situation, you can improvise on your management, all right, but then I think you can give an appropriate treatment. I think very correct. I agree with you, Bharat. And there are a couple of more questions, specific questions that suppose ST elevation, you see, it's like this. For a cardiologist who has seen the patient, who has seen plenty of patients and who knows now, for example, anterior wall myocardial infarction, who goes 4 hours later into cardiogenic shock, but has given you an opportunity to see him and treat him right in the beginning. Now, a well-informed and experienced cardiologist would know that this is the man who is going to go in cardiogenic shock in another 4 hours' time. Extensive anterior wall infarction, RBBB, something which is suggestive that this patient has an extensive anterior wall damage, and such a patient gives you an opportunity to treat him promptly. And if you revascularize, sizable amount of myocardium will recruit back by your prompt revascularization, and such patient you should not. Even though when he comes at the time of admission, he may look pretty stable. But believe me, cardiogenic shock does not develop. Here is an infarction, and now within another 5 minutes he'll develop cardiogenic shock. No. Either he dies, 50% of the patient would die before they come to the hospital. Those who come to the hospital, many of them go into cardiogenic shock 3-4 hours later. So such patients should be treated with primary angioplasty. Right now, there was another question where the ECG probably would, from what he describes, it might be inferior wall infarction with either right ventricular infarction. There was elevation in V1, but he also mentions that AVR elevation. Such patients always must go diagnostic angiography and then take a call, because these are serious. ECG signs are indicative of a very bad time to come ahead of time. Now, another few hours time, this patient will promptly go into a very serious situation. Those patients should be taken up. What I want to say that take maximum precautions, but where you feel your clinical judgment tells you that this is potentially a serious case, go ahead, don't hesitate. Offer him the treatment which you think is appropriate.
There is a question by Dr. Trivedi. He's asking how many cases you have operated in last 2 months. Not many, honestly, but I have operated on some children who had a very severe obstruction to the right ventricular outflow tract. As you know, I do both adult and pediatric, although I don't do pediatric into Just Look, but I have decided to start doing pediatric in Just Look from tomorrow. Hopefully, I'm getting a very good backup now, so I'll be doing all the children in Just Look as well. So one of the child I did was he had to have a change of conduit because I operated in, he was 2 months old, he had truncus arteriosus, and I had put in a jugular vein conduit. Now he's 8 years old and there was a gradient of more than 120 and he was going in right ventricular failure. So I changed that conduit. That was okay. 3 to 4 days back, I had to operate on a patient because there are higher and higher number of patients are now not getting, as we say, the ideal treatment because it's not always possible to do angioplasty. So he underwent thrombolysis for acute anterior myocardial infarction. And 3rd or 4th day, he was admitted because he had to wait at that time for COVID test. And then his angioplasty was done to the lady. He was okay, but on this 48 hours after angioplasty, they noticed that he was going in a very severe heart failure and they noticed that he had a ventricular septal rupture. So this was a patient who had developed a post-infarction VSD. So this was another case I had operated. and I have done some couple of routine CABGs, but that's all. I have not been able to. But now we hope to do from now onwards, maybe next week onwards, with added precautions, all the routine kind of cardiac surgery in just look, and hope to have as good result as we had before. There's another question about specific about some case which was operated and had whether it should do an angioplasty. Again, here multiple grafts, and now one of the graft is given. I think that will be a case-to-case basis. It will be difficult to judge unless we see an angiogram. I think a specific question will be very hard to answer on this forum.
So there is a question, is it clinically possible to diagnose a secondary acute MI where coronaries are normal?
Oh yeah, this question I think is very important question. Is it possible to suspect this is secondary myocardial infarction and not primary myocardial infarction? It has happened. It happened in Just Look during COVID time. My junior colleague, where I showed where he contacted me, because at that point of time we had made a rule that every acute myocardial infarction or every acute coronary syndrome emergency should be either with a joint consultation with me or with Dr. Ajit Desai. And this was to sort of a share responsibility and also to provide a guidance and in fairness to the patient. All right, at that point of time, a patient who came in, first of all, secondary myocardial infarction patients have a little bit atypical pain. Classic anginal pain is not present. Elevation of tropa is in both, but tropa elevation is much more significant in primary myocardial infarction. And then in case of doubt, like there were cases where the ST elevation, and then one could not very clearly say whether it's a primary or secondary. In that situation, I think you will have to take angiography. And that will give you clearly, if the angiography is normal, you have nothing else to do. So this, I think, right, by in general, you do get certain inklings or certain hints that this might be secondary. A young patient who has never had risk factors, never suffered from coronary disease, indications of something like that, and no family background, and then he's just been with a vague pain, and then you find tachycardia, ST elevations, that too, not sky-high ST elevation, but a little bit. I think I'll suspect secondary myocardial infarction. And then
also another question, sir, from Noor Jahan Merchant. How many cases of thrombolysis and PAMI done in this COVID season? Any mortality? How many become COVID positive who were COVID negative?
What is the question? I've understood properly. Tell me.
Sir, how many cases of thrombolysis and PAMI done in this COVID season?
Oh, surprisingly, I suspect that some of these patients who are very scared to go and visit hospital with acute coronary syndrome might have died at home. I have no idea at all, because number of admissions to the hospital has gone down drastically. Like, say for example, I would see approximately, say, 30 or 40 patients of acute coronary syndrome. And this is, they are just not simply visiting because they are keeping quiet and then they want to be on themselves. And I have no really idea what outcome has happened, whether they were remitted, they improved, or they succumbed. I don't know. But initial period, I was in the favor of doing thrombolysis if the patient came in the first 12 hours. Now that the HRCT is proved to be of a very high value, it has proven to be a very good diagnostic help in that situation, I think. And then primarily, it should be decided by the clinical condition. Dr. Suresh Joshi mentioned one thing in his talk, that if the risk of the disease itself is so very high in terms of mortality as compared to the risk of treatment, then the treatment becomes a choice. Although the risk may be higher in pre-COVID, post-COVID era as compared to pre-COVID, but you have to do it. But knowing fully well that this is unfortunate that COVID is going on. And maybe, yes, it is true that the COVID positive tests have higher mortality of everything. Surgery, angioplasty, everything. COVID positive patients has much higher mortality. Question is that if you leave him alone, what is going to be the mortality? That is a decisive factor of whether to step in or not to step in. What would you say, Suresh?
Yeah, I agree with you because if we, like this pandemic, as I mentioned, is not going to be a short-lived thing now. It appears that it's going to go on for months and possibly years. If I remember correctly, the first major pandemic of influenza way back in 1917 and 18, I'm told that lasted for almost a decade, 7, 8, 10 years. So that time, of course, things were quite different. Almost 50 million people died at that time. Hopefully, we shouldn't face that kind of mortality now with very, very advanced medical treatment today. But the time frame is really unpredictable because we are still nowhere close to the vaccine. Neither have we invented any drug to counteract this disease. So we will have to accept it. And now, like we have some patients, we say we will wait for 3 weeks. Then we say now 12 weeks. Now we say that 6 months. So not every patient can wait that long indefinitely. For somebody who has maybe a newborn baby who's got a VSD and pulmonary hypertension, he might become inoperable in the next 6 months. Or somebody has a small nodule of cancer and he may throw metastasis somewhere else. So the overall strategy of managing these kind of patients has to be changed, not only in cardiac, but all other specialties as well, where we will have to take a call and decide how long, because this how long is not really definitive, it's kind of very vague. So we will have to take additional guidelines and go ahead and do fairly routine cases with the proper precautions that they don't catch COVID infection. I think we should be able to do almost all routine surgery with that. But in an emergent situation, as you pointed out, if he is COVID positive, if you are unable to wait even for 10-15 days, which is normal time you take for the COVID to, kind of get sort of cured by itself, then we'll have to take the chance. For example, if somebody comes with post-infarction VSD or somebody is so unstable angina that he's got a global infarction, you can't do anything. You have to just go ahead and do an angioplasty, even if it is left main. Sometimes just go ahead and do it. What else can you do? Or you get somebody who stabbed you, is COVID positive, he's got a wound in the heart. Are you going to wait for the COVID? No, you cannot. You have to just take the risk and go ahead and out. So it's
just to add a little thing, that when he comes in as an emergency, he does not know that he is COVID positive or not, whether it's in incubation period. Even I don't know. In that case, I would rather be optimistic and treat in the appropriate way rather than repent at a later date that this was man who got very inferior treatment on my fear of COVID negative. Is that fair?
Yeah, absolutely. You have to err on the positive side, because on the positive intervention side, be it is cath lab intervention or surgery, rather than wait and watch kind of thing. That may be too late by then. I would be more aggressive in approaching these kind of patients.
Mind you, I think many patients who have come to the emergency area and you take a preliminary history of traveling or a contact or something and all, and there's all negative. Vast majority will turn out to be COVID negative. I do quickly HRCT, and if HRCT is good and the history is not suggestive, I would rather go and believe that he is COVID negative and treat him as COVID negative.
But even if you see the natural history of COVID, the panic and fear is so huge, but the numbers tell us a different story. 80-70% of patients are more or less asymptomatic. Only 25-30% are symptomatic, out of which hardly 10 or 15 require admission. And out of the 10 or 15% who require admission, hardly 5% go in the intensive care. And out of the 5% who go in intensive care, mortality is maybe 15%. So effectively, overall mortality of COVID is 3%, which is high. But overall, it is certainly far less compared to the severity of a cardiac condition. For the patient who fall in that majority, 75-80%, if he comes with mild symptoms, he's not going to have a problem if he has an angioplasty or if he has a routine, some small time cardiac surgery. Why should he have any problem? But the fear is really high. That fear, both not only the patient, but even amongst the doctors, they feel, oh, what is going to happen if I operate on this guy? And then there will be issues because we don't have strong scientific data accumulated as much. So that's the reason. Once this more and more data comes out about the safety of intervention, I guess we'll be more aggressive in tackling these patients.
Sir, can we take a couple of questions, sir? More?
Yeah.
Sir, one question from Dr. Vidya. Have incidences of acute coronary syndrome increased during COVID?
So, say it again.
Have the incidences of acute coronary syndrome increased during COVID?
I think sir will be able to.
Okay, I don't know the answer correctly because these patients are not, they are so scared that they are not visiting the hospital. And probably the acute coronary syndrome, I would presume that the prevalence of coronary disease can't be changed completely in last few months. The prevalence is prevalence. It's existing in the society. With the stress of COVID, probably the incidence of acute coronary syndrome might have gone up, but I'm unable to answer because I come to know only those who present to the hospital, or I come to know from my colleagues that, but everybody tells me that their work volume is down. Perhaps what might have happened, which we might not be able to consider, is that the balancing factor is the environmental pollution has gone down, stress has gone down, traffic has gone down. So people are at home. Wrong food they are not eating. No McDonald's hamburger and no pizza and whatnot. People eat home food. So all those things also might be playing a positive role from that point of view. And I think, I honestly, I don't know, but I know for sure that the incidence of presentation of acute coronary syndrome to the hospital is significantly low.
Sir, it may be the presentation is low, but if you see the world statistic, besides the normal hypertension, diabetes causing heart problem, COVID itself has contributed to a significant number of myocarditis, and which presents with acute coronaries like picture with normal coronaries, and infarction with rising troponin levels. I mean, these are also which are the complication of COVID infection that has also increased the number of acute coronary. Although in our country the panic is so huge that they don't, and the overall healthcare system is not so much comparable to the West, so they probably don't present to the hospital. But the incidence of acute coronary as a result of COVID infection causing myocarditis, arrhythmias, and sudden deaths, they have also been very well.
No, but that incidence, Suresh, as you correctly mentioned, is very, very low. Those who are getting admitted to ICU, you weed it out, filter stage by stage, that incidence is very, very low. So perhaps not that, but I think out of fear and all that, they just don't come. Everybody tells me that their work volume is very low.
Somebody is asking me here a question whether are you justified in closing an ASD at this time? I would say if you have the kind of backup and the precautions in a hospital like Jaslok, where COVID patients and the non-COVID patients are so well isolated and the possibility of contracting COVID is almost negligible, why not? Of course, the first choice of ASD is a device closure, but if you can't do the device, you should do surgical closure, and we are doing it minimally invasive techniques, so just 3 days hospital stay. So yes, certainly can be done ASD closure, or any small cardiac procedure can be done. Your experience on ECMO in COVID time, I would not be able to tell you about ECMO because we haven't used it for surgery, ECMO following surgery in COVID time, but I am sure they must have used ECMO, venovenous ECMO, for an extensive lung damage due to COVID in some centers. So I think the pulmonologist will be able to tell you more about that. If they have a further talk that time, we'll be able to. Yeah, but that is a very, very good option. In fact, a fairly large number of patients are on ECMO in America. If I'm told, one of my friend who is the administrator of one of the hospitals, he's saying that ECMO is one of the very definitive treatment for those who got such an extensive lung damage because of COVID and are not responding to any of the antivirals, and so they are on ECMO for 10 days, 15 days, and a fair number of them are recovering. Although the results are not as brilliant as one would like to be, but still the recovery is fairly good for those who are ECMO.
Right. I think somebody questioned whether the cardiac failure, can it worsen with COVID? Yes, certainly. All cardiac manifestations are exaggerated. They are much more severe in presence of COVID. Yes. COVID is a very harmful effect on symptomatology, and it may aggravate the clinically silent diseases, and those who are in compensated state, if they get COVID, they will go into decompensation immediately. Yeah. That I think.
So do corona positive AMI patients who have been thrombolized do better with coronary interventions?
Yeah, you see, it's like this. This is asking me, I presume it is in two ways. Thrombolysis successful patient and thrombolysis failed patient, or thrombolysis contraindicated. Well, we already briefly had touched the issue where thrombolysis is contraindicated, like recent stroke, recent surgery, patient have a bleeding diathesis, and intolerant for whatever reason, their thrombolysis negated, they're contraindicated. There the fallback system by default itself will be angioplasty. Now, failed thrombolysis. If thrombolysis within 1 hour's time, if the ST segment do not settle down by at least 50% of the baseline ST segment elevation, 2, hemodynamically he should continue to remain stable. 3, the chest pain should alleviate to a significant extent, and this is a successful thrombolysis. 1 out of 4 only will be successful in thrombolysis, because successful recanalization with the best antithrombotic agents like let's say tissue plasminogen activators is only 55%. Out of this, there is 1/3 of a recloser. So in bottom, the reality is that the thrombolysis really works with producing TIMI3 flow, happens in 1 out of 4 cases only. And not only that, but those patients who have a thrombolysis, they have an 18 to 20% chance to develop recurrent ischemia or recurrence of event within the hospital stay. So by and large, generally, we should prefer rescue angioplasty. Coming to where the thrombolysis has failed, you have no choice. You'll have to go merely by default to angioplasty.
Sir, I think it's been amply proven over several years that in acute cases, the real treatment is primary angioplasty rather than thrombolysis. There is very little debate, I would think, that the superiority of angioplasty rather than thrombolysis. Although if it is absolutely not available in the vicinity and you do thrombolysis, that is okay.
Yeah.
But in the situation like I said, even thrombolysis is known to cause septal ruptures and the ventricular ruptures. That is also a higher incidence post thrombolysis.
True.
So that also needs to be kept in, although it's a small incidence, but it needs to be kept in mind as well.
Sir, Dr. Sohail Faruqi, he's asking, sir, in COVID era, how do we refer cardiac emergencies in Jaslok? Will they admit on emergency basis?
That I think you have to answer, Nikhil. How do we admit, like you create a bed? That you'll have to answer that.
So we do have a suspect ward, sir, where we can admit emergency patients, and then the swab and the CT can be done, and we can segregate the patients and then hand it over to you.
CT is round the clock available.
Yes.
And I think answer to CT answer you can obtain, I think in about 15-20 minutes maybe, Nikhil.
Yes, sir. Yes, sir.
Yeah, and this I think then I think you can quickly take a decision. Basically, I'll tell you what the protocols were. These the guidelines and so. If somebody got a case of acute myocardial infarction where there is no primary angioplasty facility, no cath lab, if he calls up Jaslok Hospital or any other nearby hospital which has a possibility of operating angioplasty, if door in and door out, DIDO time in his hospital, and there he goes there, is less than 90 minutes, then I think he can transfer the patient. he should transfer the patient. And but if you find that, well, it's not possible to transfer in the 90 minutes time, actually transfer time is 2 hours, but I would say in the COVID time, it has been a little bit more easier to transport the patient because traffic is not there. The Bombay traffic is terrible otherwise. And then at actually about 90 minutes to 120 minutes of time, angioplasty can be offered. But this is the point. But question is that before sending, you must give aspirin at least, and maybe ticagrelor. Or ticagrelor is very fast acting, 20 minutes to 2 hours. So I think I can wait. And if you send the patient, that should be fine.
So also one more question by Dr. Ritin, I suppose. How long should we wait for elective cardiac surgeries in a patient who is COVID positive at present? Fairly asymptomatic in terms of his cardiac disease at present.
Well, if elective cardiac surgery can be done within 2 to 4 weeks after the end of COVID treatment, I guess. Especially if those are like, just COVID positive, they have not been in the ICU. Now, there are a couple of long-term complications of COVID that we still have not understood clearly because it's a new disease. One of them is progressive pulmonary fibrosis, but that is more common in patients who are in the ICU on ventilator for a longer time. For those who have a mild attack, which is most of the time 80-85% of the cases, it is hopefully expected that they will not develop any long-term pulmonary complication like interstitial fibrosis. So that is one thing which can add up to the complication of cardiac surgery in a delayed way. But I guess if you have a COVID attack, you have waited for 2 to 4 weeks. After 4 weeks, there should be no reason that why we can't do a routine cardiac surgery.
Sir, Dr. Gadkari Kanchan is asking whether decision should be only on the basis of patient's condition as it was before the COVID, without any consideration of anything else, such as protection of the medical team, as it is expected that the team is supposed to take universal precautions. As with the same thinking, no one should be admitted in ICCU. Patients with severe pneumonia, as the RMOs in the ICCU are exposed for much more time than a cardio team who is exposed for 1 hour. If the patient condition does not allow intervention, should be excluded.
I haven't really got the question, honestly. What exactly he wants to know?
So whether like previously, which we used to do without any consideration of anything else, such as protection of the medical team.
Yeah.
So as it is expected that the team is supposed to take universal precautions.
Yeah.
So as should be admitting ICCU patients with severe pneumonia, as the cardio team is more exposed for maybe 1 hour. So should we be excluding these patients or should we do this?
I'm not sure exactly what he wants to know. Okay, can you?
Okay. Meanwhile, Suresh,
yeah,
there's a question for you and me combined together.
So,
that's an interesting question. Lima and radial is patent, and the patient had received a stent in a vein graft, and that stent was 4 years ago. So now he has come with the NSTMI, non-ST elevation acute coronary syndrome, and there is a stenosis proximal and distal to the previous stent in the same vein graft. Should he be subjected to stenting or a medical treatment? Now, I'm sure that you will supplement to what I say or differ, whatever you decide. My impression is that the second bypass surgery, wherever it is possible to postpone, after all it's a palliative treatment, you should try to do that. In presence of patent Lima, which is probably the best graft ever discovered in this so far era, and radial also is, now I read that is far superior to the vein grafts. So probably this vein graft must be in one of the circumflex branches or one of the right coronary branches. And you know that the event rate in any vein graft, when it reaches to a stage where we have to intervene, the event rate in the next 2 years' time is 50%. In other words, a degenerated vein graft will keep on giving troubles over a period of time in soon or later. But I still feel that a symptomatic patients not responding to adequate medical therapy should be offered another stent and give him a chance and keep on working. And currently available stents, the second generation stents with the cobalt chromium and also with Lima's drugs are more durable, and there is no perfect data on the vein grafts and vis-a-vis non-vein graft. There is no RCT that I know of, but I think I would still prefer to offer him a stent rather than to send him for surgery in presence of a patent Lima and radial.
Yeah, I agree with you. I see one of the things that is undisputable is the advantage of Lima LED bypass. In fact, this is one operation that has been, in fact, voted to be one of the greatest inventions of 19th century or 20th century, where it has saved more life than any other operation. Lima to LED. So it's greatest, and if the Lima to LED is patent, the patient is really well protected. Now coming back to the vein graft, now it's already what I would say is that more than just looking at a graft, we need to study the case and find out how much is the myocardium at jeopardy, how much percent of really this vein graft is supplying. It seems that from the description, probably it's very minor. And maybe it can be treated either very aggressive medical management, or one may attempt to do a vein graft. But as you rightfully said, that once the vein needs a stent, it has lived its life. And maybe we can postpone it for maybe another few months or a year by another stent. So no harm in doing that. But vein graft, one vein graft gone, and other two arterial grafts are patent. Depending on what the age of the patient is and depending on how much is the myocardium at jeopardy. If it's a large myocardium at risk, then one may consider surgery, but if it is a small area, you can definitely treat by either aggressive medical management or repeat stenting, whichever it is technically feasible.
Okay, Nikhil, when is the time to say thank you?
Sir, Sheila is waiting for that, sir.
Yes, sir. So on behalf of Jaslok Hospital, I would like to thank all the cyber participants for their keen and active involvement. Big thank you to our speakers, both Dr. Ashwin Mehta sir and Dr. Suresh Joshi sir, for sparing their valuable time, especially on a Sunday morning, and for delivering very insightful and informative presentations. Thank you all for attending, and look forward to your involvement and participation in our future activities as well. Have a nice Sunday. Thank you.
In a lighter note, I would have, any other situation would have said, it's okay, I did manage to find some extra time, and it was always a pleasure to do extra work for Jaslok. But in the present COVID time, I am looking forward to such things. I can actually use my time, and hopefully now we are increasing the surgery, so I will be getting more and more busy with this medical operation. But once the fear from the people's mind to go to the hospital comes down, we'll be able to come back to our normalcy very quickly. So it's a pleasure joining the webinar, and any academic activity, we are always very, very willing from Jaslok team. Thank you.
Thank you so much, sir.